Now, common features of ion channel disease are that they are genetic and inheritable conditions. They exhibit variable penetrance, which is a genetic term describing variability of expression in individuals in a family, even when they carry the same mutation, from being severely affected to only being mildly affected. And this is a common feature across the disorders. Normal cardiac structure is usually the case, although not invariable, and ventricular arrhythmias are a common end pathway with the risk of blackouts and the risk of sudden death, and this is why we're here today. Now, the diagnostic scenarios that are particularly relevant to this talk are those of a suspected athlete on the basis of either being symptomatic or having abnormal ECG from screening, or both. Or there may be a family history of underlying ion channel disease or a family history of sudden death, whether it's premature, clearly autopsy-negative sudden death, or related to an underlying diagnosed condition. Now, I'll be referring to this particular consensus statement, and this is also published in Hard Rhythm, and it's in your references in your abstract book, and I think this is a worthy document to look at in terms of for future reference. I will also be referring to the ESC and Seattle guidelines that you've already seen described amply. This slide is a summary of some of the work from Mary Shepard in young sudden cardiac death victims, and just in yellow outlines to you that sudden death with a normal heart, or where you may expect a normal heart morphologically, where the cause may be put down to arrhythmia, represents a significant proportion of sudden death. Cardiomyopathy is still the most important cause in athletes, we would think, but normal heart should not be missed as a potential etiology. But in this setting, the interpretation of ECG anomalies in athletes can be very difficult. As you've already seen, physiology of athletes results in the athlete heart phenotype of increased vagal tone, slower heart rates, and this can therefore affect depolarization, repolarization, and arrhythmic manifestations. And this overlaps clearly with pathology, and differentiation of these two aspects of the ECG are vital. And so in terms of ECG interpretation and the ESC criteria, I'll just pick out those that may be relevant to ion channel disease directly. T-wave inversions in the right ventricular leads and Brugada-like repolarization are clearly related to diagnosis of Brugada syndrome, while conduction abnormalities, premature conduction disease, and QRS prolongation are important, and these clearly are uncommon and training unrelated changes. Long and short QT intervals are also listed as group 2. But here in group 1 is early repolarization, which is a more recently described ion channel disorder, which I'll touch on as well during this talk. So let's move on to long QT syndrome first. It has a population prevalence of about 1 in 2,000, is heritable, as you already know, has normal cardiac structure, and the ECG manifestations are related to delayed cardiac repolarization. This is the expert consensus recommendation on long QT syndrome diagnosis. It may be diagnosed in the presence of a long QT syndrome risk score of more than 3.5, and I'll go through the risk score with you in a moment, and in the absence of a secondary cause for QT prolongation. Otherwise, in the presence of an unequivocally pathogenic mutation in one of the long QT related genes, in the presence of a corrected QT interval that is repeatedly severely prolonged in the absence of symptoms, and secondly, a more intermediate prolongation of the long QT, of the QT interval between 480 and 500 in repeated 12-lead ECGs in the context of unexplained syncope may be considered the long QT syndrome as well. So there's been a widening of the diagnostic criteria to try and improve sensitivity while maintaining specificity. Now, this is the LQTS Risk score, previously devised by Schwartz and Moss in 1993, with a revision in 2011 by Schwartz. And in particular, I want to point out to you in red the ECG measures that indicate long QT syndrome, and the scoring clearly, the scoring, if there is a, here it is. The scoring as you increase your QTC interval gives you a higher score, and once you get to 4 or more, you get a high probability of long QT syndrome. What's new is here, the recovery QTc interval at about 4 minutes of recovery of the excised ECG, if prolonged, can add a further degree of certainty to your diagnosis. And this is the addition made in 2011. Other factors such as symptoms, congenital deafness, and family history will also contribute to the diagnosis. Clearly, with the criteria of scoring, this is not necessarily always the easiest diagnosis to make. In terms of how to measure the QT interval and correct it, this requires measurement of the QT interval as accurately as possible, and this can be fraught with problems when trying to identify the end of the T wave and where the U wave interacts with the T wave, and measuring the RR interval. And the Bazet's formula involves the square root of the RR interval, and abnormal has been described as more than 440 in males, more than 460 in females, and more than 440 in children. The Bazet's formula, though, is not particularly accurate if you go faster or slower than 60 beats per minute. So just beware that this is a rather unhelpful measure in itself. And how does that relate really to QT measurements in athletes? Well, this is complicated by bradycardia, sinus arrhythmia, slightly widened QRS complexes in some cases, and as I said, the TU wave complexes as well will make determination very difficult. In addition, there's data that the prevalence of QT prolongation in the general population, according to the above cutoffs, is relatively low, but much higher using those cutoffs in athletes. And this has been shown by some data from our team, Sanjay's team, already, where around 1 in 200 athletes from Sanjay's cohort had QT prolongation according to those accepted criteria, but in fact those athletes who had other features that would be supportive of long QT syndrome and would raise a long QT risk score up to something significant exhibited QTc intervals of more than 500 milliseconds. Those with less than 500 milliseconds did not have additional features. And it is recognized, therefore, that a longer QT interval is important in distinguishing athletes from with normal repolarization from those who don't. And this is the reclassification according to the Seattle criteria that we already had mentioned by Nabil. Other supportive diagnostic features are important in the asymptomatic individual who's not going to achieve that risk score level, or who has an intermediate QT interval. Notch T waves, particularly notch T waves in more than 3 leads, and particularly in pediatric cases where notching in V1 to V3 is quite common. That's an important feature to watch out for. And this is the exercise QTc interval that I mentioned to you, and it's prompted by one excellent study from from Kran's group in collaboration with Amsterdam and Israel. And this shows you a chart of the exercise ECG from supine, standing, peak exercise, and then recovery, and looking at probands and replicating it in genotype and non-genotype probands. They were able to distinguish carriers from non-carriers accurately using the 4-minute recovery time, and this is with a sensitivity and specificity of around 90%. So this is why it prompted Schwartz to say that this should be included in the scoring system. This is an example of a long QT2 patient who had a baseline ECG that was normal. And this was actually a symptomatic patient as well. I'll just point out that these U waves are quite prominent, and this is more common in athletes and more common in long QT syndrome as well. This is the LQT2 3-minute to 4-minute recovery time on the exercise test for that same patient. I'm a bit concerned as how we interpret those U waves in the context of recovery, and how the biphasic nature of the T waves that you see there can be distinguished from a normal TU wave. We can say amplitude looks similar, that may be a normal TU wave pattern, but how certain are we when we're trying to differentiate pathology from normal behavior? So I would say we still have to treat this test with a little bit of skepticism when we're applying it to athletes in particular, but that we should still try and evaluate it in that context. genotyping can certainly be helpful. And in true definite long QT syndrome, we're getting pickup rates using the top 3 genes of around 65 to 70% for the sodium channel and potassium channel alpha subunits that are involved in the long QT syndrome. But I would like to caution you when you're looking at cases that are intermediate in their probability of carrying a long QT, and this may be relevant to those borderline athletes, that the sensitivity will fall to 30%. So genotyping is not necessarily going to be the answer in most cases. Other diagnostic methods that may help you include epinephrine challenges and orthostatic QT changes, the lying and standing ECG tests. And the epinephrine challenge here is particularly useful for trying to differentiate LQT1 carriers. This is from a Japanese protocol, but there's also an American protocol that's a little bit different. But it's able to pick out carriers in the setting of families who have normal QTC intervals from non-carriers in the same family. Applying that to probands presenting index cases with suspicions for long QT syndrome who don't have a family history have not been evaluated. So only in the family setting are we certain that this offers some value. The lying and standing ECG is similar. It's also been looked at in the family setting where you have an index case and you've been able to genotype other family members. So not necessarily relevant to an asymptomatic athlete turning up out of the blue. It is a simple provocative maneuver, however. With continuous ECG monitoring, the maximal QT stretch is the measure that has been advocated as being most helpful. And this is when the T wave is closest to the following P wave immediately after standing, and you measure that QT interval. This is an example over here of a long QT2 carrier who has normal QT interval at rest. That's standing, and this is the maximal QT stretch over here, giving a value of 556 milliseconds, which is well over the cutoff advocated by the Israeli group who've suggested this particular test. And this is an example of an LQT1 resting female with a normal QT interval, albeit at the end of normal range, who with standing develops a maximum QT stretch of 520 after 19 seconds, and this is also advocated as diagnostic by this test. But again, the sensitivities and specificities are around 80 to 90% in the setting, however, of family disease. Now I'm going to move on to Brugada syndrome. This was first described as the entity of Brugada syndrome in 1992, although there were some preliminary descriptions of a similar disorder in 1989. And it's also been related to sudden unexplained death syndrome in Southeast Asia, known by various different terms, like type or Kuri Bungungut, but these are all sudden death in young males in particular, although the spectrum of the disease seems to affect middle-aged men as well, particularly in Western populations, but it is more common certainly in Southeast Asia. And the main concerns are polymorphic ventricular tachycardia and ventricular fibrillation as the manifestations of risk, and paroxysmal atrial fibrillation is certainly very common. The characteristic ECG of the Brugada syndrome is transient and concealed many times, but may be present continuously in some cases, and that they are the less common cases. Most carriers are concealed. Now, this is the typical type 1 ECG pattern, and these are the type 2 and 3 ECG patterns that have been described in the past. These may be considered as one group, and they're not in themselves diagnostic of the Brugada syndrome. They're in fact normal findings. Particularly if you elevate your ECG leads up to the high right ventricular leads, you'll see about a 2 to 3% rate of type 2 and type 3 ECGs in normal individuals in the general population. Now, this is one of the diagnostic tests, sodium channel blocking test, and we use Ajmaline here in the UK, but procainamide is used in the States and pilsacainide in Japan, for example. But we think Ajmaline is probably most sensitive. And this baseline test, you can see, demonstrates a normal ECG and then evolution of the type 1 Brugada ECG pattern to a full-blown pattern after 3 minutes of this test. And the consensus recommendations for Brugada syndrome diagnosis have become a little bit wider on this most recent iteration. It's diagnosed in patients with that type 1 ECG pattern, and that's the type 1 ECG pattern only, but in a single right ventricular lead, and that right ventricular lead can be in the standard or higher right ventricular leads in the second and third intercostal spaces. And that can be present as spontaneously or after provocation with a class 1 antiarrhythmic. In addition, if you have a type 2 or type 3 ECG at rest, and that converts to type 1, that is also the Brugada syndrome if it converts with sodium channel provocation. There are no other requirements. Previous criteria required additional clinical factors to make a diagnosis, but that is no longer the case. Genotype doesn't help with diagnosis here, generally because the yield is relatively poor and the association with disease is problematic at times. Where it is helpful, though, however, as illustrated by this particular pedigree, we'll look here at the sister and brother, is for evidence of conduction disease. So this index case was the sister in that pedigree who was a sodium channel mutation carrier and demonstrated quite clear evidence for sinus node disease and for AV conduction disease. The brother exhibited non-specific intraventricular delay and borderline QRS prolongation with the type 1 ECG pattern seen in the standard and in the high ventricular leads in the third intercostal space. That's represented in that third group of ECGs there. Now, how does that compare to the athlete's ECG, where we see a lot of right ventricular changes, as Nabil's already shown you? Well, this is the type 1 ECG pattern, and a recent consensus document has suggested that if you measure the J point or ST elevation and compare it to the ST elevation 80 milliseconds after that point, the ratio will be greater than 1 to indicate a Brugada type ECG pattern. And that if you take examples here of the athletic ECG patterns of anterior early repolarization in these V1 to V3, that ratio should be less than 1. I think visually it's probably easier to just see it rather than to actually make the measurements and make the ratio, but this was, I think, stating the obvious. And this may be stating the obvious to Sanjay as well, since he's been looking at these patients for so long. And this is particularly important to the black athlete population, and these are examples from Sanjay's cohort. And you can see that all these changes, the J point elevation is below that of the ST elevation. The T-wave inversion can be quite dramatic and even make you think about whether arrhythmogenic right ventricular cardiomyopathy is present in these individuals. As you've heard from Nabil, that's not the case. In terms of how to treat these Brugada-like ECGs in athletes, if there's presence of significant conduction abnormality, if the type 2 pattern is there, particularly if they're a non-black athlete, then you must have a higher suspicion, I would think, that these are relevant ECG changes. And then I would use right ventricular high leads to look for a type 1 pattern, consider Ajmaline provocation, and you may also think about considering an MRI scan for ARVC in these cases. But bearing in mind the changes in black athletes are relatively common, or extremely common. Just quickly mentioning premature cardiac conduction disease, as you can see, it can associate with the Brugada syndrome, but it can be its own entity, and it's diagnosed in the presence of unexplained progressive conduction abnormalities in young people, in the absence of other skeletal myopathies, especially if there is a family history for premature conduction disease, so if there is a history of pacing or device therapy. And this is recognized as an abnormal finding based on the Seattle criteria and on the ESC criteria, but I'm a little bit skeptical about this cutoff of 140 milliseconds. That looks to me as being very long. I would be concerned about anybody with a QRS of 120 or over myself. But that's up for debate. I'm not sure how good the evidence is on QRS with QRS durations in athletes. And certainly here you've already had this mentioned by Nabil, the recognition of the black athlete early repolarization pattern. CPVT is catecholinergic polymorphic VT. Exertionally related ventricular arrhythmias, typically bidirectional and polymorphic, and especially seen in children, and occasionally first presentations in adults. And it's particularly successfully treated with beta blockers and flecainide and sometimes sympathectomy. And ICD therapy may occasionally be required, and it's been linked in around half of cases to the ryanodine receptor as the gene responsible. And therefore, mutation analysis may be very helpful in diagnosis. And this is an example of a mother of a young person who had a cardiac arrest age 14, and she had been completely asymptomatic, but in fact, when she exercised, she had characteristic bidirectional ectopics, and we proved this case on the basis of ryanodine receptor mutation testing. So you may still see this in older individuals and athletes. The epinephrine challenge may also be helpful in those individuals who don't show much or show very little signs in their exercise ECG, and you're worried about CPVT as a diagnosis. And this is from family members of cardiac arrest survivors that they managed to show some utility of the epinephrine test over the exercise ECG. In terms of the expert consensus recommendations on diagnosis, it may be diagnosed in the presence of those characteristic ECG patterns in a young person with structurally normal heart and a normal ECG. And it can be diagnosed in patients who have a pathogenic mutation, or diagnosed in family members of a CPVT case, no matter what age, provided they manifest those characteristic ECG patterns for arrhythmia. And it can be diagnosed in the presence of a structurally normal heart that's been thoroughly evaluated in individuals older than 40 years if the ECG pattern is present as well, that bidirectional or polymorphic in exercise-induced VT. Clearly, coronary artery disease is important to exclude in these cases. There is one concern, however, about the ECG challenge in athletes. Sinus bradycardia is a common finding in ryanodine receptor mutation carriers. U waves are also very common, and the ECG is otherwise normal. So if you really have a strong suspicion for CPVT based on symptoms, then you have to identify the characteristic exertional arrhythmia, because that is not common, that's very rare, and therefore a stress test is mandatory if you're going to make that diagnosis. Just to touch on a few of the other rarer entities, this is an example of short QT syndrome in a cardiac arrest victim, extremely short QT interval with highly peaked T waves. And the short QT syndrome is also an extremely rare condition, less than 100 cases that fit the criteria described in the literature. And the QT that is short enough to make a diagnosis has increased over time up to 360 milliseconds in the literature. And cardiac arrest, syncope, and atrial fibrillation are the common features. It can readily be treated with ICD and quinidine, but what do you do with an asymptomatic short QT interval carrier? We have no consensus on that at the moment. In terms of the expert recommendations on diagnosis, this cutoff of 330 milliseconds was settled on for any individual presenting, whether they're symptomatic or not, with a short QT. The short QT can be diagnosed in the presence of a slightly longer QT of less than 360 if you have other factors such as a mutation or a family history of sudden death or a family history of short QT syndrome, or if there's been a prior resuscitated cardiac arrest. Not much room there for asymptomatic individuals above 330 milliseconds, and the Seattle criteria use a similarly stringent interval cutoff of 320 milliseconds. Now, I'm not sure about the data on short QT intervals in athletes. I've seen very little on that myself in the literature, and whether they truly are shorter to warrant a 320 millisecond cutoff, but that's certainly something where more research would be useful. This cardiac arrest victim is my sort of final area of interest for this talk. Immediately after his resuscitated cardiac arrest, you will note that he had infralateral slurring of the QRS. This is known as the J wave or J point elevation. And in fact, this person went on to have further VF episodes associated with further exacerbation of that QRS slurring. And this is a rhythm strip taken from the defibrillator just prior to the onset of the next VF episodes, and you can see that the J wave comes up and then VF happens. and that seems to settle once defibrillation has occurred. This is a characteristic condition. This is characteristic for a condition, early repolarization syndrome. But unfortunately, as you can see on this follow-up ECG in this patient, the J point does not look particularly remarkable, and you would be struggling to say that this patient was a cardiac arrest survivor. Otherwise, this would be an idiopathic VF patient. Early repolarization itself was initially described by Wasserberger in 1961 and described a prominent notch or slur in the terminal QRS, this J wave, with a concave ST elevation. And note that ST elevation is part of the diagnosis and seen in the anterolateral leads, so also including the right ventricular leads. And this was not particularly common in the general population across all age groups, but was more so in young men, amongst blacks, and amongst athletes. And it was considered a benign finding. Now, this has changed since a number of observations and then a seminal paper by Hasseguer and colleagues, where they described cases of idiopathic ventricular fibrillation, so cases of cardiac arrest that had been resuscitated with no other underlying cause detected, and they found a much higher prevalence of early repolarization changes seen in these cases, 31% to 5%, compared to age-matched controls. And there were young males having cardiac arrest in sleep, and they also had a high evidence of recurrent VF, but they had redefined early repolarization. J-point elevation had to be present in 2 leads, slurred or notched, as with Wasserberger, but the inferior leads were the main site of interest rather than anterolateral leads, and ST elevation was not necessary, and indeed most of their cases didn't necessarily have ST elevation. And the prevalence changed for this type of J-point elevation to 6 to 13%. In various different general population studies. There's little data, however, on the family characteristics and what to do in asymptomatic early repolarization in relatives, for example, of these sorts of individuals. And in terms of what's been found in athletes who've suffered cardiac arrest or sudden cardiac death without structural heart disease, this is a paper from an Italian group. They identified an exacerbation of the J wave or a heightened J wave in any lead with a 3-fold odds ratio compared to control subjects and even an 11-fold odds ratio with inferior and lateral early repolarization changes. But early repolarization is so common and normal and event rates are so low that it is clinically meaningless in the asymptomatic individuals. So it's an interesting observation, but where do we take it when it comes to the asymptomatic athlete being screened? And this is an example that Sanjay kindly gave me of one of his very typical early repolarization ECG patterns infralaterally with an upsloping ascending ST segment. And I mentioned the upsloping ST segment because this was then studied in a general population follow-up study from a Finnish group who have been pioneering early repolarization as an entity in the general population. And when they looked at this inferior horizontal descending pattern, which is different from that upsloping ST segment pattern and associated with the inferior notching or slurring, so maybe something more akin to the Hasseguer changes, they see this sort of behavior. They see a much worse longer-term outcome compared to general population without ER and those with upsloping ST segment changes. So I would say to you that in fact asymptomatic athletic early repolarization is still benign, and please don't consider it pathological unless you've got other reasons to believe that. So the expert recommendations for ER diagnosis are all focused on sudden death victims or resuscitation of sudden death where there's reasonable evidence for early repolarization. If it's an asymptomatic person, it's an ER pattern. It's not early repolarization syndrome. We should not be implanting patients with ICDs who are asymptomatic with the ER pattern. So you'll be glad to hear that it's going to be time for coffee. I conclude that there is much overlap of the athletic ECG with ion channel disease. It's greater amongst blacks. Newer criteria may reduce these false positives, and you've already seen some very positive work done by Sanjay's group. and additional clinical investigation may be prompted by symptoms, by family history, and the athlete's wishes as well. Thank you.